In what other industry could a purveyor put out 99% bad bills and stay in business?
Yep. Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare. Let's get kicked off, guys. Really excited about this podcast. I'm here with Linda Komisak. Did I say that?
Komisak.
Komisak,
yes.
the COO of CareLuminate, and I've got Kimberly Carleson, the CEO of US Beacon. Welcome, guys.
Well, it's great to be here.
I'm excited to have you. This is I'll position the podcast, and then I want to get you guys real quickly to just sort of state in your own words what you do separately. But I do think there's an excitement in my mind, co-equally what each one of your entities do, but then the combination of the two is a really compelling use case there. And so I'm glad we're going to tell the story together. But Linda, why don't you kick us off real quick? What is CareLuminate?
CareLuminate is democratizing what healthcare workers have done for each other for years. We are, if you needed a medical procedure, you would call somebody in the medical field that you know to say, where should I go? Who should I see? So CareLuminate is really just looking to help communities understand their local healthcare differently by hearing about the quality from the people who work there.
So it's a big focus on quality. And
yes.
I would say maybe it's a novel way, and you may disagree, a novel way to measure quality, at least the way that we do it in an aggregate way. But you were telling me that when we get into it, nurses kind of already know this information today and share the information of quality together, right?
Right. And doctors often ask nurses, where should I go? What we think is differentiating about CareLuminate is these quality elements that we're talking to nurses about will resonate with patients far more than a CMS CAUTI score or a CLABSI score. Those things are important in terms of that hospital getting reimbursed, which we'll get into in a little bit, but it doesn't resonate to a patient. And let's be honest, 4-star CMS hospitals let me say it the other way around, a 2-star CMS hospital is just as full as a 4-star CMS hospital, because patients don't know what that means. And I don't think if they knew what it meant, they would necessarily follow a physician to a 2-star hospital.
Awesome. All right, so we've got the quality side with CareLuminate. Yes. Kimberly, what does US Beacon do?
US Beacon is a claims integrity review.
Okay.
So we take, after the TPA auto adjudicates the bill, they send it to us. We go through, we find 30 to 45% of ineligible charges on each claim. In network, out of network, will go up to 70%.
Yeah. So a massive amount of, whether we want to call it ineligible charges, fraud, waste, and exploitative practices.
Trying to be nice.
Depends on your position. But this claims integrity, and I've heard it sometimes referred to as bill review, to bill audit, to payment integrity, or a combination of those things. I think claims integrity is a great way to put it.
And we're careful to use the word audit.
Yeah, I understand that, right? There is and I actually want to talk about that in a moment, why review versus audit and what those words might trigger. But I do want to give you some kudos real quick, and I was telling you over coffee, you popped on my radar, I don't know, maybe 6 months or so ago now, because you're really effective at using LinkedIn. I mean, incredibly effective, to the point where you're usually my first post of the day that pops on my feed when I jump on, because I always read your posts. And the reason I always read your posts is because every single post actually has substance that's interesting, that tells a story, and I gain something from it. So I at least wanted to applaud you for doing a really good job.
Thank you so much.
She gets a crown.
Yeah, and
it's LinkedIn, yes.
All sort of like, it's not even tongue in cheek, but all joking aside, it's an incredibly effective way to get your story out. I've benefited from the application and the commitment to using LinkedIn. I think just telling you and just you knowing that's without LinkedIn, I may not be aware that US Beacon existed. And so I think it's a testament to your commitment.
And it's just bringing awareness of what's going on right now with the medical claims. So a lot of people don't realize.
Yeah. Well, it couldn't be more, the timing could be more important, I think, for this, because we were talking earlier about the CAA. Obviously, we're talking over coffee about, unfortunately, Marshall Allen's passing and the book Never Pay the First Bill. I think there's just a groundswell of sentiment right now, ultimately, that we know there's so much pork built into hospital bills. And at the end of the day, the individual American taxpayer is ultimately the one that's footing that bill one way or another, right? So it feels like a fight for the good guy, the little guy. And so I want to dig into that. But before we go really deep into the actual subject matter, why don't we learn about you guys real quick? And so Linda, I'll go back over to you. Give me some of your backstory, how you got into healthcare, your nursing career. I'd love to hear about you.
So I have been a registered nurse for about 1 million years now.
Okay.
Feels that long, doesn't it?
It does. I spent several years in emergency departments, trauma departments, ICUs, burn units, and saw some. I mean, I knew back then the story I told you about the obstetrician that had a 30% bowel perforation rate. I saw that back when I was still working at the bedside, and nobody was incented to do anything about it. And it didn't really click to me that there was an opportunity there. Went back to school, got a business degree, went to work for some of the big EHR vendors, focused in academic medicine, then moved into the private equity space, some venture capital owned companies, and had a conversation with Taylor Davis, my business partner last year, about really looking at quality differently. And it resonated with me as soon as he said, I want to talk to nurses about what's going on in hospitals. I was like, yes. Why did I think of that?
What is it about the nurse's voice that's so important in cutting through the noise there?
Well, this is really interesting because I think there's this perception when you talk to a nurse about what's going on in the hospital, it's going to be all negative. And so when we started our research, I just expected to hear complaint.
Yeah.
That's not at all what happens. Nurses are super specific. We do this really well. We don't do that really well. We could do better here, but I would absolutely not have a family member here. So we open our research with nurses asking, would you have a family member treated at the hospital where you work? And that inspires the most interesting conversations with nurses. I don't know if you've ever read McCary's book, Unaccountable.
I've only read The Price We Pay. I haven't read Unaccountable.
So he talks about how spine surgeries are often not necessary. In this book, he talks about how providers have the best bedside manner and the worst patient outcomes. And when they're high volume, nobody's going to do anything about that because they're bringing business in the door.
Yep.
So it is, when you talk to nurses, there's a sense. First of all, they're employed by the hospital, and they want to show up to work believing that they're doing a great job every day, but they will so quickly tell you when they know they're being asked to cut corners.
Really?
Absolutely.
Okay. Because their focus is the patient themselves, right?
Yes, that's what nurses do.
They're not tasked with the revenue side of it, right?
Correct.
So unburdened somewhat from that.
Right. So nursing rates are tied to the room rate in the hospital. So nurses get paid by patients being in the bed. There's nobody else in the hospital who spends more time with the patient than a registered nurse.
Okay.
So if you ask nurses what's going on in the hospital, and you ask the right questions, they'll tell you if it's clean or not clean. They'll tell you, yes, I'd put my mom here, or no, I wouldn't. I'd send my mom over there.
Yeah.
We went into it thinking we were just going to hear horror stories, and that's not at all what we heard. We heard there's a hospital. Am I allowed to mention hospital names? Okay. There is a health system. There's a health system in Raleigh-Durham, North Carolina, where the nurses consistently say, we deliver exceptional care. I don't get paid as much here as I would at another health system here in the area, but I love working here. And if I need help, it's not unusual for me to see a nursing leader come down, put some gloves on, and help us. That's unusual. We don't hear nurses talking so positively about administration as much as we heard at WakeMed in North Carolina. WakeMed is very proud of the WakeMed way, and they don't pay their nurses exceptionally well to be there, but they pay them enough and they treat them well. And they spend their money on the other resources that nurses need to feel like they're being successful that day.
Yeah, and I'm going to put a pin on there and we'll come back to it, but I want to comment on that. I think a lot of companies, and hospitals wouldn't be any different, miss the opportunity to really infuse their mission in their daily operations to attract the right type of people to come work for you, even if you can't compete solely on wages alone. I think there's a margin in there where the majority of people, when given that proposition, would actually choose an option that maybe paid them a little bit less, but they had a mission every day and they believed in what they were doing beyond working elsewhere. And they were inspired to be there on a daily basis.
And they had the right support,
Exactly,
right? So maybe you pay registered nurses a little bit less, but you make sure that there's a CNA available on the shift that can help with all the patient care things that the registered nurse wouldn't be able to get to. Or maybe hospitals bring back LPNs to assist with the things that the RNs are doing but couldn't do. We heard in other hospitals that are not WakeMed, we heard oftentimes about nurses being responsible for cleaning the rooms and taking the garbage out. What?
Yeah.
Why are you paying nurses to do those things? You could pay nurses to actually do registered nursing things that they're licensed to do and have somebody that you're not paying as much do those other things. And I don't know why hospitals don't get that.
Yeah.
I've worked in the industry for so long and I still can't wrap my head around why you're paying nurses to take the garbage out.
Well, it's a unique animal in and of itself. But I want to give Kim a chance. Yeah, no, I want to.
Yeah, please tell me.
Please comment on that. And then,
With the nurse, do you see a nurses shortage?
No,
Right now you don't.
There are over 200,000 nurses that are not employed right now because they choose to not work in these conditions.
Oh, wow.
So there's not a nursing shortage. There's a shortage of nurses willing to work in the conditions that they're being asked to work in.
Right.
Okay, I wasn't aware of that.
There's over 200,000 licensed registered nurses that are not working because of that.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
I want to dig into why in a moment.
Okay.
I want to give Kim a second, though. I think your story of how you found yourself in this crazy world we call the healthcare or the benefits system is pretty interesting. So I want to hear from you real quick. How'd you get here?
Right.
Doing claims integrity.
Sure. I got a degree, or have my degree in public health and radiologic technology. I worked in the hospital system as an X-ray tech.
Love our X-ray techs.
Yes. Well, I watched how a lot of people were treated. And so it kind of gave me a passion for the patients there. But my biggest reason of why I'm here is my husband was diagnosed with stage 4 cancer. And that was the biggest fight of my life because I had a daughter in kindergarten and I was pregnant with my son. And when my son I was 4 months pregnant and I was told I was having a son. And 2 weeks later, I was told that Steve had 2 weeks to live. Wow. I mean, not 2 weeks, 2 years to live.
Most,
I'm sorry,
right?
yes, 2 years at most. Yeah. 2 years at most. And so when they told me that, I thought, no, he doesn't. Not with me around. So I went and researched everything. I called every hospital. None of them would take him in because he was too far gone.
Okay.
And a lot of hospitals don't want to run their statistics.
So he was too risky of a patient.
Right.
They didn't want to see.
They didn't want him to die.
That
they didn't want
it of the system itself.
Exactly.
Right.
They didn't want him to die. So anyway, he was a member of the Rockefeller, or on the board of Rockefeller Cancer Institute, luckily, by the grace of God. And we found a friend that's a surgeon that said, you have a death sentence. You either go in, and this sounds really explicit, but gut yourself. We gut you and see if we can pull a Hail Mary, And so we did. We went in, we took out Steve's bladder, prostate, and 48 lymph nodes, and I didn't know if he was going to make it through that surgery. So
Well, the beauty of that story, I would say, at least from what I know, is that was 17 years ago.
17 years ago.
And Steve is
It
just
has
to my
not-
right off camera. He's
He
still
is
here,
just
thank
to your
God.
right over there. And it has not been an easy 17 years. It's been in and out of the hospital, C. diff, sepsis, things that would
Yeah.
put you down. But I have fought every step of the way. At that time, we didn't have Facebook or anything, so I got on blogs and would talk to women. I told the oncologist what chemo I wanted administered to Steve.
Really?
Yes, which is called the Red Devil. It's adriamycin. It's the worst chemo you can have.
Can I tell a story about adriamycin?
Yes.
When I was working in the hospital, a bag of adriamycin broke, and it was on the floor. It took the finish off the floor.
Oh, yeah.
Whoa.
Yes.
Okay.
And
And
they
is
were
it red, I
injecting it.
presume that's why it's called the Red Devil, or what?
The Red Devil
It's
is the worst.
incredibly toxic.
Yes, it is.
But incredibly
it kills.
effective.
It does. It kills every bit of cancer if you can live through it. That's what
Right.
they
If
say.
You could live through
Right.
it. Okay.
So, Steve, there was a lot of problems with that, and we had to fight every step of the way. And I was involved and made sure that if a doctor told us he wasn't going to make it, that the doctor was fired. And we moved on to the next
Yeah.
doctor, and I just didn't take no for an answer, and that became my passion.
Yeah.
To help people throughout that. So
That kind of advocacy
Yeah.
is
you
Wow.
have to do stand up for yourself,
right.
and you have to
And you
take
have
it
to
in
know.
your own hands.
But that means you have to know, right? So you can advocate for yourself when you have great information that's readily available, and you don't have to spend.
and you don't have to listen to a doctor.
Exactly.
Yep.
You go and I'm not saying that in a bad way.
No,
'cause
no, I
there's
get
so
what
many
you're saying.
respectable, wonderful doctors out there,
Sure.
but a lot of them don't have your best interest at heart. Just like went in just recently because he has to have a kidney transplant now, Red Devil, and all of that, taking all of those pieces out of him has caused his kidneys to go down.
Okay.
We've taken one out. We have one left, but he's at stage 5 renal disease. And the doctors, we waited 6 hours for the kidney to get there. We were prepped. Our kids, we were all crying. We were so excited about,
Yeah.
that we were going to have our dad back, my husband back. So my son's over there putting the glove of the hospital gloves on his head, 17-year-old boy. He makes it real enjoyable. But so when the kidney got there, it been in a car wreck, and it was not in good enough shape to put in him. But you know what? They could have put that kidney in him and made money, but they didn't.
Right.
And I appreciate
Right.
the careful attention that they took to that. So you find good ones and you find
Right, and that's
good ones that are
kind of the premise of Care Illuminate, I would guess I would say, is like it's not to demonize a system, an individual, anything like that. It's just to measure them. And if you are somebody like one of us that enters into that system and at the mercy now of it for them to take care of you, you would like to know going in, is this even a good hospital in the first place?
Right.
Is my physician, my surgeon,
Right.
any good at what they
Right.
do? Or did somebody just say, well, this is what you need and here you go, without any intelligence to the decision-making process being applied?
So
That's all I want.
Outside of surgery, outside of Steve's surgery, where the surgeon was actually at the bedside doing surgery, how much time did that surgeon spend at the bedside when Steve was up on the floor? 15 minutes?
that surgeon was a godsend.
Okay, so maybe that's not a great
We
example.
no, it's not. We still see that surgeon. He moved to Lakeland, Florida, and we go to Lakeland, Florida to see him.
Okay.
He was amazing.
But
He was exceptional.
which is wonderful, and I'm so grateful
Right.
that you had that experience. But
Right.
so often the surgeon does the surgery, the patient goes up to the floor, the surgeon comes in and spends 10 minutes a day at the bedside with the patient and leaves. It is available by phone or Tiger messaging systems and is in communication with the staff, but is really only spending 10, 15 minutes at the bedside on a daily basis. It's the nurses that are delivering the care that physician ordered or didn't order. And it is the nurses that are trying to fill the gaps in when there are things missing from what that physician should have ordered. It's the nurses going to advocate for the patient to the physician. So those are the things that the nurses will be super transparent about with us when we talk about it. Okay. So it's not to demonize anyone. It's really to say, this is what happens.
Right.
When you come into the hospital, you'll see your surgeon 10 or 15 minutes, if you're lucky, at the bedside after the surgery.
Well, the CEO at the last company was when he came in and was taking ownership over of the company to a degree and putting his spin on what we were doing. One of the things he told us early on is, I don't care what it is, I just want to know what it is. And so his whole thing was good, bad, ugly, bruises. Tell me what's going on and don't shy away from telling me the stuff that needs to be fixed. And I look at that with from a nurse's voices, they're going to tell you what it is, whether that's a good thing or a bad thing. At least you know, at least an objective truth that comes out of that analysis that you're doing at CareLuminate. I want to finish off your story just so we can. Sorry. That's okay. No, I just want to crystallize for the folks that I don't know your backstory, the culmination that turned into US Beacon. How did that come to be? And I want to dig in a little bit more to what you guys specifically do with claims integrity. So flash me forward there to how it was created.
So Steve was with Merrill Lynch for 30 years, 35 years. He was over 30 to 45 states. His biggest clients were insurance companies. When he got sick, he had to go out on disability and then early retirement. So he started investing in things, and that's where US Beacon came into play. We started with workers' comp. It started in 1995. He was a small investor in the company. And then it moved on to where we became 100% owners. We have no investors. We are independently owned.
Amazing.
We are strictly here to help navigate and help patients like what we went through. Because if I didn't have a financially intelligent husband, we would not. That may not be the way to say that, but if we would not have been diversified, we wouldn't have made it through.
Sure.
We were in C. diff, we were in, sepsis, we were in the hospital constantly.
Yeah, right.
So we would not have made it through. So luckily I had because if it would have been up to me, but
well, I think the point there is when we get into your bill review services, there's, I think, a story you told me of a lady that's going through a $700 bill, right? That could financially break them. And so when you get down to, like, what does the average American have stowed away in savings or the ability to cover an emergency a medical bill, these are things that could bankrupt, and they do often bankrupt.
I just read an article about that. I saw the average American family has $400 to spend.
Right.
Yeah. How many hospital bills do you know that are under $400?
That might be an urgent care.
60% of the bankruptcies are due to medical debt.
Yes.
Now,
and I think the most astonishing part of that stat is over 80% of the people that do go into that cohort of bankruptcies because of medical debt, over 80% actually were insured at the time of that event happening as well.
Had insurance.
And then dig into how many of those are healthcare workers themselves.
Oh, really? I haven't dug into that.
So do you remember? Again, I don't know if I should name the names, a health system in Tennessee that was suing its employees for medical debt.
I remember something like that.
I don't doubt it. I mean, how's that for an employer?
Right?
Yeah.
So you offer me the plan. I can't pay the bill. And so you're going to sue me for what I can't pay for at your hospital?
Well, and so
that happened during COVID.
Yeah, if you talk to me about what motivates me, it is the fact that the majority of Americans are underinsured or functionally uninsured as a result of their inability to actually use the insurance that they pay for. I mean, that you talk about why I care about self-funding, why I care about claims integrity, why I care about quality scores. It's because everything we need to do is to dig into all that unnecessary spending in healthcare so we can lower the cost of health insurance, lower the cost of the healthcare delivery system itself, and make it affordable and accessible for every American.
Yep.
I think I just summarized my entire life mission statement.
Right.
But this thing is so important to me.
For sure.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSite supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSite. Visit plansite.com now to book a free demo and discover the future of insurance renewals.
So I want to now ask the question, why together? Let's talk about what you guys both do.
I love her.
Because we have fun
Outside
together.
of you guys love each other. Why is CareLuminate and US Beacon collectively kind of a supercharged combination of a solution?
I think it's about value. I think it's about helping communities understand the value that they are getting out of their local healthcare. So in what other industry could a purveyor put out 99% bad bills and stay in business?
Yep.
So there's the financial piece of it, but then it's what are you actually buying? Did I need that surgery? Did I need to be admitted? Could I have
medically
had this,
necessary?
Is it medically necessary? Could I have had this treated or handled in another way? So I think when you talk about healthcare value, and I think CMS is doing super important work, being able to tie specific quality metrics to what the hospital's reimbursement rate is going to be. I think that's a great step in the right direction. The problem is that doesn't resonate at the person who's actually paying for healthcare. We have to stop calling the BUCAs the payers of healthcare, because the real payers of healthcare are the employees and the employers.
Right.
Yep.
So let's call them the carriers.
Okay.
I think the employee who sees an 8% increase in their healthcare premiums doesn't necessarily understand what that's buying. So I think the real beauty of CareLuminate and US Beacon is helping communities understand value. Where are you being overcharged? That's not a value. Where is the care excellent? That is value. And when we can get to the point where we're tying our quality data with their billing data, we're going to be able to tell a super powerful story in a community where it's happening. Imagine you would know which hospitals in Dallas offer the best care and which of those are overbilling consistently.
Yeah.
That does not exist today. So
And then define a network or direct contracting
Right.
model with the ones that are delivering the best value, right?
And you can't say that a health system is good. I use the example of St. Luke's in Kansas City, that it was recently acquired by BJC out of St. Louis. Two of the St. Luke's hospitals appear to be extremely good. The nurses love them. Two of them are not so good. So when an employer goes to contract with St. Luke's, they may be contracting at the hospitals that aren't so great.
Right.
And how do you know? How do you really know until you know what are you paying and what are you paying for?
Yeah.
So that's how I think the partnership works really well. I'd love to hear.
I think that benefit administrators are starting to realize, or benefit advisors, they're starting to realize it's super important to, number one, we could get in trouble. Their lawsuits
Yeah,
are
absolutely.
opening it wide open.
Yeah.
So we've got to take care of our plans. And so that's just...
Good care costs less.
Right.
Good care in a hospital
Huge misconception that
costs
people have. Yeah.
less.
It costs less.
We have a, can I tell a story? This is a great
you
story.
certainly may tell a story. Yeah.
Another hospital in Kansas City, owned by a very large healthcare corporation. Patient came in on a Friday with symptoms of appendicitis from his family doctor and was admitted to the hospital. They never told the patient that they don't run radiology and surgery on weekends. Patient's appendix ruptures. So what could have been at any other hospital that continued to run CAT scans and surgery over a weekend, what could have been a 6-hour in and out laparoscopic get the appendix out, turned into a 6-week ordeal with an open abdominal wound and IV antibiotics for that patient. Who paid for that? Not the hospital. So it's stories like that. If a patient shows up in the ER and you're not running CAT scan and they have symptoms of appendicitis, are you responsible to say, we can't really treat you here. You should go somewhere else. And a hospital will never send a
gonna say,
patient out the door.
Business model do you do a horrendous job, jeopardize somebody's life, and get paid exponentially more while you do it?
Right? Right?
I would love to see another business that operates like that.
Exactly. So I would also, I would love to get my hands on that patient's bill.
Yeah.
We've done a couple of Kansas City hospitals, and I will say.
Well, Kim, I want to actually talk about the business model itself, because like your model and the savings that you guys find, it's my understanding it helps actually fund these studies as well. So tell me how that works.
Correct. So we find enough employees in a certain geographical area.
Yeah.
And they join US Speaking, or we use us as a resource for claims integrity, and we give a percentage of that to CareLuminate to fund the studies.
Okay. And so when you're looking at an employer, what's it like? Give me an average employer. Like, who's a good fit for you? Is it a self-funded employer? Is it a fully?
It's always self-funded.
Always self-funded. Okay.
Always self-funded.
And then size range wise, like how big would this employer need to be?
It just depends on the area.
Okay.
And that we have a list of every
so we've
area.
done the math across every metropolitan area in the country. So for Denver, for example, we need 13,000 belly buttons. So 13,000 people covered on claims review for us to get the research kicked off in Denver.
So just knowing based on your average ability to save money for that size population, you'll easily be able to fund this study, and then of course deliver savings.
When 99.9% of the bills have ineligible charges, we'll be able to, after that.
And so then you go to these employers and pitch this value proposition itself.
Correct.
So it's a review. It's not an audit, right? Like, let's define
It is a review because you only get one audit a year.
Yeah.
So you have to say review.
The word audit obviously sounds scary. If I was being audited by the IRS,
right?
Sure. Right. So that's a red flag type of thing. Yeah. So what keeps it below the threshold of being a true audit then?
Well, an audit you can only do once a year according to plan language. And an audit, the BUCAs will give you the data quicker than if you do a review.
And an audit is really, here's what you, it's super high level. Yes. It's not very detailed.
It doesn't show as much. Once you get into those itemized statements is when you find that sterilization or a pacemaker.
7 colonoscopy implants.
Yeah, 7 implants into a colonoscopy or a deceased person. So you find all that in the itemized statement. What they're paying on is a receipt.
Yeah,
they're not paying on anything else. Exactly. They're adjudicating bill, paying on the receipt, and not looking at anything.
You had a post about that recently, I think. I remember.
I did.
Which is really eye-opening for me, because it's really just, it's almost like if I were to submit my expenses as an employee for Pareto and I just submitted the total and said, pay it, they'd go, no.
Can you imagine?
They go, okay, where did you go? What was the date?
Right.
Who was there?
And you went out to dinner and had 6 bottles of Camus, right?
Yeah, exactly. Right. Yeah, this $1,000 receipt, just pay it. It's cool. Yeah.
Is what's amazing to me is they count every pen, every sheet of paper at a business, but they don't pay any attention to their health plans.
That gives me another story to tell about on the quality side when they charge for things like that. We actually talked to several nurses at a hospital that were told they had to bring their own pens to work.
Oh, because they wouldn't buy them pens?
Oh, my goodness.
Because they would not pay for them.
Can you get them some USB computers?
Right? We were like, what's your address? We're going to
some CareLuminate pens.
Yeah, right.
But if I'm an employer, though, and I want to ask you about the Kansas City study next, but if I'm an employer, what would I expect for this process? Like, how do I get it going? What do I expect as sort of average savings if there's a ballpark number? If I'm entering into this equation, I've never gone through a review before, a bill review, what do I expect to have happen?
You will have 4 to 7% savings overall spend.
Okay.
So let's say a plan, I'm using a large plan here, 150,000.
Okay.
They have a 600 million spend. 54 million would be the savings.
Okay. Mm-hmm. And so that's just looking at all bills over what, a certain
10,000 or above. But we can look from 0 up because we can hook into the system and take every single bill. We can take your largest bills. We can take 10,000 above. We'll do whatever. We're a resource. We sign no contracts.
But the $10,000 mark,
You're going to see more savings.
Well, you're going to see more savings. It's going to make the
And
effort.
we do a proof of concept before to kind of give you the ammunition to go in and say, hey, look, I'm the fiduciary. I'm finding ineligible charges here. I need this amendment put into my contract. And
send to their plan document to make it. But I would look at it, and this is where the CAA, I think, supports what you do, or it supports the category that we call claims integrity. They have a fiduciary obligation to spend the plan's money effectively and efficiently.
Right.
They have a duty to their employees. And so you would look at this, and this bill review to me almost becomes an obligation at some point.
Right.
I don't know if there needs to be an identification of a trigger, almost like probable cause, in law, but if there's something that they can point to and say, hey, we found this, now it's our obligation to go review these.
The first thing they're going to tell you, though, is we already have that in place.
We're already doing it.
But it's owned by them.
Yeah.
And they get 30% of the
Them
savings.
being what, the carrier?
The carrier,
TPA?
They buy out them. I mean, you don't know that they've bought them out, but if you go back and look at the, way back,
Who
that they have.
actually posted that? Was it Preston Alexander actually posted on LinkedIn all the acquisitions around?
They own the bill,
and
yes, like claims integrity.
I think it was.
But in the contract, they get 30% of the savings.
Right.
So we were working. I don't know if I should. I think there's some things you wonder, should I say this or not? We were working with a company, and they had overpaid, and working with the TPA, and he was like, "Well, y'all found savings, so I get 30% of those." We thought, no.
Well, that's not how that works.
Exactly.
But that's why it's so crucial for the independent element in my mind. Because it's like, if you buy the entity that's reviewing your own adjudication, and then now you're making 30% off of your own mistakes or your own oversight.
Right.
How is that?
Right.
Right.
At all.
And most of the bill review companies are owned by private equity, or they have investors. I mean, it's something that none of them are independent.
Yeah.
And
they should be. And they absolutely should be. I want to go to the Kansas City study, because I've talked to Taylor on a couple occasions. He shared it with me. I've shared it with some colleagues as well. I think that's maybe the most robust one Careluminate's done to date. Or why do we reference that study so often?
Well, we spoke with nearly 500 nurses across 23 hospitals in Kansas City.
Okay.
So it's a very representative view of what's going on in Kansas City.
And so what did you uncover? Like, tell me some big things that you found out.
Well, the appendix story that I told you happened in Kansas City. And you as a healthcare person can go in and read, and Joe Blow off the street can go in and read exactly what the nurses said at the hospitals in Kansas City on our website. We're looking to build the TripAdvisor of healthcare, right? So you can go in and get the insider view of hospitals. So in Kansas City, I think the example I showed you over coffee this morning, there are 7 hospitals that offer cancer services in Kansas City. At 6 of them, the nurses say, don't come here.
Yeah.
So
that's amazing.
So 1 out of 7 they recommend.
Yes. So the nurses at those other hospitals say, yeah, I'd send my loved ones to KU.
Okay.
So at these 6 other hospitals, they're still offering the cancer services, but the nurses would say, I wouldn't have my loved one.
Well, that's when I raised that question to you, because it was a colleague of mine, a confidant, when I presented this, and I said, this sounds amazing, this is great. He said, yeah, but here's something to think about, which is that nurses, he said, nurses might just be disgruntled, or nurses might feel underpaid or overworked. And so they're going to maybe perhaps have a negative sentiment for the place that they work. And you were very quick to sort of object to that and say that actually didn't come out in the findings. So I want to hear, because I would presume, right, if that is the case, I would have negative bias to the place of work or against it. So you would think the results would show that every place is terrible then, if that's the result, and that wasn't what came out.
Or conversely, nurses have so much pride in their work that they're not going to tell you that they're cutting corners, right?
Fair,
so there's the other side of that,
Yeah.
which nobody really goes to that side of it, where the idea that nurses are being asked to cut corners, right? And they know it.
Yeah.
So, so we, and obviously I can't show you here on the podcast, but we have statistical relevance around each of our quality metrics that we looked at. And we've been able to correlate it to CMS stars and HCAHPS ratings and leapfrog ratings. So we don't have any any outliers. Our statistical, every single response that we post on the website falls within a very predictable statistical relevance.
Well, and I think too, you said Taylor, I asked you, how'd y'all come up with the research model? Taylor's a brilliant
statistician. Yes.
Yeah, and how long does it take to conduct a study like this?
Depends how big it is. Okay. But we have a bench of 1099 nurse contractors that we can scale up pretty quickly to go attack a larger area. But for Kansas City, we started research in late July, early August, and we had it wrapped up by November.
Okay.
With the report published. So August, September, October, 3 months to talk to about 500 nurses. And it's really, our secret sauce is really getting the nurses on the phone. Yeah. So if I told you how we did that, I'd have to kill you because that is
we don't have to reveal your trade secret.
That is our trade secret, is our ability to get to nurses and get them to every single nurse we talk to scheduled an appointment to talk to us.
Wow. Well, and I asked you though, so why don't you just do it in an automated way? Why isn't it just a drop down or a check the box kind of thing? And you had a really good answer for that.
Yeah. So we tried.
You are talking to them.
Yes, we're actually conducting 20-minute interviews. We tried putting it online and just having nurses go fill out a survey and they would just check the boxes, right? And then we'd pick up the phone and call and say, I'd like to talk with you more about this at your hospital. And it was through those conversations where we found things where if nurses answered anything other than glowingly positive, one of our questions is, I have confidence that my loved ones will receive the safest possible care in this facility. And then they rank it strongly agree, neutral, disagree, strongly disagree. So the Likert scale. And when a nurse said anything other than a 4 or 5, we picked up the phone and said, can we talk to you about this? And in those conversations are where the nurses would reveal things such as, we have a high fall rate in this hospital and we only have 2 lifts for the entire hospital.
Okay.
Other hospitals, we heard there's a lift in every single patient room. So when you take that commentary that doesn't come from a checkbox and you can start to correlate it to mortality after a fall in a hospital, that becomes really interesting to understand why that mortality rate is what it is. Taylor and I went into this thinking, oh, hospitals are going to love having this information. They'll know not only what's going on in their own hospital, but their competition down the street, right? Hospitals didn't care. Hospitals were like, nah, not interested, go away. Yeah. So conversations with nurses revealed data that we wouldn't have gotten out of just an online checkbox.
And you're keeping their identity and like anonymous.
Absolutely.
Right? So you don't want any retribution from the hospital, right?
And we validated every single nursing license.
Okay.
So we made sure that we were talking to active licensed nurses in that state.
Because the last thing though you would want to see is the hospital identifies an individual in your survey that gave a negative review and fires that. I mean,
nurses were that's part of the hard part about doing this and assuring anonymity. Yeah. Because the nurses working in these hospitals are like, nobody's going to know about this, right? Because I'll lose my job. Mm-hmm.
Oh, yeah.
There's a lot of fear.
Yeah. Right.
Because they're almost, in a sense, whistleblowing to a degree.
So I was thinking,
Absolutely. So we guarantee anonymity. And where there's any triangulation. So if a nurse says, I work in the ICU only on weekends, anywhere, we strip that out. Like any way to be able to triangulate who said what.
No, that's Becky. They would go, oh, that's Becky.
And if it was somebody like Becky, Becky is still screwed. Becky's still going to be on her way out. Becky's going to be a travel nurse in no time.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
So tell me about the timeline then, Kimberly. So let's say an employer that has a large enough sample size of a population to be able to fund a study, you guys do your reviews first, right?
Right.
So what are you
Right.
collecting? Like, tell me what that employer needs to provide to you so you can get the ammunition
Right,
you need.
sure. So we need the itemized statement, the UBO4, and the EOB.
Okay, and that's all you need to
That's
get
all
going.
we need.
Okay.
And we'll go through that, and we can have it back within 24 to 72 hours.
And so that's a quick turnaround. So
Right.
one to three
We
business
have,
days.
we run it through the AI system,
Yeah.
as they all do, but we also have doctors look at it. We have contracted out doctors that look over
scrub it.
every single bill.
Because you're trying to find everything you possibly can.
Right.
So what happens next? So we've identified 7 to 9% savings across the board. Are these claims mostly post-adjudication, so they've already been paid?
No,
Okay,
no, they have not been paid. It's prepay. We do look at post-pay sometimes, but it's harder to collect on
It's harder to
those.
claw back, for sure.
But these are prepaid, so once we look at them, we send them back to the plan. They send them off to be paid, and
And is it going back to the TPA then at that point, or who is
Yes.
the entity? Okay, so then they're reprocessing, if you will, those claims, or
Right.
going to the provider and denying those ineligible charges and things like that. Okay,
they're
I
seeing
just
that.
wanted to
And then
put
we
the
take
map in
care
my
of,
head.
our appeals rate is 1/4 of 1%.
Oh wow.
We take care of every single appeal because it's just absolute ineligible charges that they know they cannot have on the bill.
Yeah. And then, but what about things that go outside of the category of ineligible, things that are just an egregious charge for a device, right? So it's the device maybe was
Implants
warranted.
are huge.
Okay, implants are huge.
They're always egregious. Let's see, the other day, I don't know if I was telling you, I did a pacemaker bill, and there's a bundled charge for the surgery of pacemaker.
Okay.
They charge $74,000 outside of that
For the device itself.
for the device itself.
For a non-FDA approved
non-FDA
device.
approved device.
Ah, okay.
We did a lung transplant, $1.5 million.
Yeah.
And we got it down to 200,000, but the company had signed a contract, so they ended up paying like 400,000.
Still,
for
though,
it. But
1.5
still,
million to
1.5 over
400,000.
400,000 is huge.
I mean,
Yeah.
that
is-
that
and it's
hit your MLR in a different way.
Right. It is all a charge that should have never been on there. Like they'll put sterilization that should be in the bundle charge of the surgery.
Right.
It's already in there. That
Right.
code is in there, but they code
So
it
it's
again.
just-
I
Right.
particularly love the IV push nurse charges. So the nurse the nurse stands at the bedside and pushes a medication, and it costs $780.
Yeah.
The nursing rates are in the room rates.
Right.
Well, not to mention, I mean, like if you go to an auto mechanic, he's not charging you by step he takes to go back and forth.
It took me this long
Yeah.
to install oil in the or to get rid of the oil in the
And
oil.
everything around me getting to the oil being changed is part of the cost. Right?
Exactly.
I took a drink of water. That's a $7 charge.
Right. Right.
Yeah, it's $7 a
Well,
minute.
what about the instance, and I've actually experienced this myself on my son's bill, and I partnered with a different entity at the time because I wasn't aware of you guys. And they upcoded the level of the severity of the ER. How do we catch things like that where the actual condition itself didn't warrant a level 5, but they charged a level 5 anyways? How do we identify those
I
things?
have a personal experience
That's why,
with that
because
too.
we have doctors look at it.
Yeah.
And they know.
They know.
And that is so common.
I know.
to code
I found out.
level
I
5.
found out.
Here's the thing that blew my mind in the past 2 weeks is the insurers are going in and upcoding based on documentation they find in the medical record. Did you see that article?
No. No.
Oh, I read this last week. I'll send it to you.
Okay.
So
Send it to me too.
So,
I'll look at
okay.
it, yes.
So insurers have nurses that are going into medical records and upcoding and changing problem lists so that they can justify or bill more. I had an interesting experience. So back in 2019, I was treated for a pretty serious condition, and I was looking in my Epic My chart in the last few months, and I saw that it was it was off my problem list. And I saw that it was back on my problem list. I'm like, that is not an active problem. And I called my primary care doctor's office to say, why is this back on my problem list? This isn't something I'm still being treated for.
Sure.
And my doctor couldn't answer that question. My doctor didn't know how it got back on my problem list. But having that on my problem list for every bill, every encounter I have with my primary care physician gets upcoded because that problem's on my problem list, even though it's not an active problem. So consumers can start to take some control over what's being upcoded by making sure that they're looking at in their patient portals to see what is listed as an active problem for that patient.
You hate to be like, I don't know, look at it from a really, really like doom and gloom lens, but at some point you feel like as an individual, you are a pawn so that you get entered into a system and then two entities decide how much gets charged and back and forth and then gets extracted from the economy. And you just are the vessel to achieve that end of extracting that money.
Yes.
And it feels really dark like that.
It does, but there's U.S. beacons in the world that can help us with that.
Yeah.
Another thing too, they're diagnosing things for things that you don't even have.
Right.
And that's scary.
It's really scary.
Where is there an end to this?
Well, and again, the research that's been done on the number of recommended spine surgeries for people that should really be treated. I don't know anyone that's had a successful spine surgery.
Right.
It seems to be a recurring, periodic, needs to be revised thing. Once you start, has to continue to happen.
Yeah.
And there's research out there that says, maybe spine surgery really isn't the thing to be doing. But neurosurgeons don't get paid unless they're doing spine surgeries.
Yeah, you cringe at the speed at which you go from pain or indication to a surgical event. Like it's astonishing speed because you're right. If those surgeons, for better or worse, and some are highly skilled and highly, conduct themselves with integrity, but they're not getting paid unless they perform a procedure.
Exactly.
So they have financial incentive to perform a procedure.
And I don't know how many surgical subdural hematomas are coming in that they can work on. So how are they going to fill the rest of the schedule? And that's
So
a
it's an
whole other.
opportunity, right? It's an opportunity for revenue.
Sure. And the other side of it is when surgeons are owned by the health system and they're given metrics, you have to see 15 patients a day or 25 patients a day. Well, you gotta fill your calendar with people who need to have stuff done.
Well, so let's move towards. I think. Well, did you want to say something?
I want to say, did y'all see the article about one of the bucas? They had a recording on it. I posted it probably 3 times because it was, buddy codes.
Buddy codes, yeah. Why don't you explain what that is in case somebody didn't read that or hear that recording? What's a buddy?
So a buddy code is to put a code on top of a code that's you really don't have. So they're putting a code on top of a code to charge you for it and put more. Yeah. You're paying more.
And the buddy is it's like it goes with this other code, and so therefore is that an indicator?
It's less likely to be discovered.
Okay. And so this was an intentional act, at least.
And it was the nurse that was the whistleblower, right?
Yeah.
And so, yes, it's an intentional act. So who do you trust on, and well, thank goodness the nurse was the whistleblower on that. But
I think if it comes to my bill, I'm going to trust US Beacon.
well, that is why you need an independent. I always stress that independent.
Yep.
Not someone who's worried about an investor or, someone, whoever owns them. You need independent to review your bills.
But I would still be fair. It's a business. You make money.
Oh,
then you
sure,
should.
for sure.
Like that's what I'm always very clear. I am pro-capitalism to only to the degree that it doesn't become crony capitalism or a politicized version where they're picking winners and losers.
Right.
I'm absolutely in favor of people making money. It always comes down to, well, how and how much money are you making? And as long as those are both justifiable, your business provides value to a marketplace. And that's what capitalism is in the first place. It's an exchange of value voluntarily. And then what happens is when it goes in the dark or behind secret contracts and things like that, when we don't know what the value being exchanged is anymore or what we're paying for.
And the value's not equal.
And it's not equal to the amount
The value is not equal.
And we're at the mercy of those two entities deciding both of those sides of the equation. That's what I have a problem with.
Me too. And I think that's back to what is Care Illuminate doing? We're really looking to illuminate the value in a healthcare system. Because right now, the only people who have that transparency are the people on this side of the equation.
Yeah.
And you and me and you, we don't have that level of transparency without going through some extra steps to get it.
What I want to do with the last 10 or so minutes of this podcast is let's like crystallize this for if I'm a consultant listening to this and what do I do next? I'm interested, intriguing value proposition, whether one or both of you guys combined. What would I want to do first? I would want to engage with you as speaking first, right? To find the savings, to get a big enough pool of dollars, obviously, to pay for CareIlluminate's efforts. But then where was a good place geographically that we're starting to target that we need to run a version of the Kansas City study, to get going?
Name a city.
Name a city.
Name a city.
Does it have to have a certain population size, or are we identifying above 500,000 people or number of hospital systems? Like, how do you qualify what's a good application?
Well, for statistical purposes, for us, it's really good to have at least 2 health systems.
2 health systems
in the area. If there's only one hospital, we do not want to do anything to discourage people from going to their local hospital. Healthcare should be local, and so we're not interested. I don't know if Taylor would agree with this, but I'm really not interested in measuring rural health centers and community health centers because they serve an incredibly important purpose for getting people to where they need to be if they can't manage it there. So there is we'd like to see 2 health systems and really pit
at
them.
minimum. And how many nurses would really be required to be credible at that point too with 2 systems?
Depends how big how big the hospitals are. And gosh, the math escapes me right now.
That's all right. I mean,
bed size for how many interviews we need to do.
Yeah,
and I'm sorry, I'm blanking on that right now.
That's all right. We'll put it
I
in the
can
post.
get that to
We'll
you.
put it in the post later. Well, what I will say though is ultimately I want this to lead to an action. My hope is that obviously, again, both of these are compelling for a number of the people who are listening, but where to go next, right? That's ultimately, it's like, hey, I could do this for my group. I want to stimulate that level of thought. And right now, I think you said there's 5.5, call it 6 studies that have been done. Obviously, every single geographic metro would benefit from this being done in a way to fund it in a seamless manner, because ultimately it's coming from savings that
Right.
Unless Amazon calls you tomorrow and says, we need this, we need bill review, then we could fund the entire country.
Right.
I mean, you could even think, I was telling you, like, I feel like this rises a level, and this is a subject just on my brain since this week's podcast I released was public good pharma, and this notion of a public good. There is a public good that results from both of y'all's operations where you could see why wouldn't we fund this? You can see certain entities might be scared that they get reviewed or they get audited or whatever you want to call it. Like, yes, I get that. But this is something that just, it seems so obvious for an employer to pursue. One, as a fiduciary, but 2, to help their marketplace benefit as a whole. Because God forbid they find themselves entering into one of those bad systems in the future and now are subject to that poor quality of care that could be received. Yeah.
Good care costs less.
It does, yeah. And so it can cost less by funding it through claims
Exactly.
savings as well. So why don't we do this, guys? And I think we could go really lofty with the end of this podcast and what does healthcare look like in the next few years? And I don't know I think if you guys both do a really good job, I think the answer would be healthcare looks a lot better than it does today. So I'll ask you both real quick then instead, just kind of closing thoughts. What would you want to leave somebody that's listened for the hour or so today of parting ways? What would you want to impart with them in terms of wisdom or things to be thinking about? Whoever's got a good one can go first.
I think that every employer needs an independent third-party review. If they charge you, they're probably not in it for the right reasons. US charge you if you don't find savings.
Okay.
We charged you $0 if we don't find savings. That's how certain we're going to find savings in every bill we review. I think it is crucial in order to change healthcare. And I think that it has to be ineligible charges, fraud, waste, and abuse to keep it healthcare sustainable, to keep it on the right track. I think that everyone needs that review.
Well, let's say
in place.
You said 7 to 9%, and just put some numbers to it. Let's say it's 10%, just for easy math. If 10% of all healthcare was
spend for a year, right?
That's $450 billion.
Right.
That's $450 billion that could be just lopped off the top of healthcare spend and redistributed back to individuals or employers through the form of savings to lower the cost of healthcare from day one, right? We can do that or year one, if you will, after a year, $500 billion of potential savings right there.
Right.
Seems like.
And you
why
know what's
wouldn't
so funny that, and this is, we're ending, but what's so funny, the larger companies don't care as much about it. It means more to the smaller companies.
Every dollar of healthcare waste, fraud, and abuse is somebody's profit.
you? Yeah. Well, and every
So-
dollar
It is, for
of
sure,
savings
for
is to their
sure.
bottom line, which increases enterprise value of a business. So if I'm a business owner and I save
Sure.
$1,000, $100,000, it's $100,000 to my bottom line that I've now created more enterprise value, the value of my business itself.
Absolutely.
By just shaving that off my bottom
And
line.
imagine how you could leverage that to become the employer of choice in your
exactly.
town. We have
Right.
great benefits here, and this is what it looks like for you.
And your premiums
But
don't keep going up.
that $500 billion that you were talking about is somebody's profit. So it is going to be really hard to bend this curve, and it's going to be really hard
Yeah. Oh, yeah.
to break this down because that's $500 billion of somebody's actual profit.
Yeah, of course.
So
Right.
so I love the mission. I love the mission.
Yeah. Well,
I love the mission together.
Yeah, the mission together is great.
And I don't know if you wanted to add any, color to closing thoughts, or if that's where
No,
you wanted to
just
finish.
the TripAdvisor of healthcare.
Yeah.
Go find out what your hotel's going to be like before you stay there.
Yeah. There you go. I love it.
Find out what meat you're buying in the grocery store. Don't
Where it
just
comes
take the
from.
receipt
Right.
and pay off of UBO4 because that's what the Bucas have all told us. We just pay off of UBO4. We don't get an automized statement. Well, what?
Right.
You know, like,
And
What-
for us, it's understand what your experience is going to be like when you're a patient in a complicated hospital gown under a sheet with machines going beep
Yeah.
and getting woken up every hour for vital signs.
yeah.
Well, I can't thank you enough. I know you traveled in not too far from Frisco, so you were down the street. But Kimberly, I thank you for coming in from Arkansas, and Steve as well. Thank you for getting her here safely.
Happy to be here. Thank you for
Thank you for
asking
the
us.
basket as well and the cookies. I mean, that's the nicest thing anybody's done for me on the podcast.
That can be your kids' sleepover.
Oh,
they can
there
eat some
you
of the
go.
cookies.
Yes,
Yeah,
there you go.
There you go. You got
sugar
dessert
bowl.
time. It's
Sugar.
sugar bowl. Sugar. Yep.
Well, I told you I got happy hour tonight, so
Yeah,
my wife
right.
will agree with that. But no, thank you guys again for coming here and telling the story. I wish you guys.
I love what you do. I appreciate it so much.
Spencer, thanks for having us.
I just feel grateful to have this forum. So again, thanks for your voices, and I can't wait to release this episode.